Hi, I previously posted this appearance without explanation. Late chronic hypotony can occasionally occur in eyes that have had a trabeculectomy, often years later. Sometimes there is no visible bleb, so it is assumed that the trabeculectomy has failed, and the hypotony is due to another cause such as ciliary body insufficiency or a cyclodialysis cleft. A very simple diagnostic test of trabeculectomy function in such circumstances is an AC injection of SF6 or other gas. The gas or air must be injected at 6 o'clock, otherwise it will come straight back out through the needle stab wound, which it does to some extent anyway, as seen in this case. However, if the gas enters the subconjunctival space causing conjunctival emphysema, then the answer is clear, i.e. the hypotony is due to an overdraining trabeculectomy with the ultimate diffuse bleb, no visible bleb at all. The solution to the hypotony is therefore to repair or patch the trabeculectomy flap. Here is another example. This eye has a flat anterior chamber and hypotony 18 months after trabeculectomy. That has previously been revised for hypotony more than a year ago. There is no visible bleb, so it is tempting to assume the trabeculectomy is not the cause of the hypotony. However, in a hypotenuse eye with the trabeculectomy is always the cause until proven otherwise. Choroidal effusions have improved after viscoelastic injections, but visco injections are not a permanent solution. Within seconds of injecting 20% SF6, there's dramatic 360-degree conjunctival emphysema. So, the absence of a visible formed bleb does not exclude the possibility of trabeculectomy overdrainage. Instead, this simply represents the appearance of the ultimate diffuse bleb, i.e. no visible bleb. 1 hour later, most of the gas has escaped into the subconj space and the AC is flat again, so I will inject some Helon 5. The intention is to try and maintain the anterior chamber until revision surgery can be organised. The gas does not always enter the subconjunctival space immediately. The first patient in whom I used this technique in 1999 had developed hypotony 6 months after a phaco trab. Although no gas was visible in the subconj space after the injection, gas was visible under conjunctiva the following day. Occasionally, after gas injection, revision surgery is no longer required. In this very photophobic eye that I showed at the start, the IOP was 14 mils mercury and the choroidal effusion had resolved 3 days after the gas injection. 10 months after the injection, the IOP was 17 mils mercury without glaucoma medication and the visual acuity was 6.5. So, although I have used this as a diagnostic test in cases of severe hypotony, pressures sometimes normalise after. But occasionally the trabeculectomy may also fail as a result. Nevertheless, this simple technique has proven useful in elucidating the cause of hypotony in many cases over the years. I hope you find this interesting. Thank you very much for watching.